and gentlemen. Today, good to see everyone here is online. So today, facilitating is myself, Kozia Ziambo, and I've got a team here with me that on the hub that we'll be interacting with. And so we'll have also Dr. Priscilla Mulenga, who's going to give us the didactic, and then we'll have a case coming in to discuss much later. So before we continue, we'll just want to invite Priscilla from the hub here to come to just give us an overview of what we were discussing in the previous meeting. Priscilla, to you.
Good afternoon, everyone. Last week's echo session was on U equals to U, which stands for undetectable equals to untransmittable. It was defined as a global movement about how effective treatment as prevention can be if scaled up widely. It also means that people who take antiretroviral therapy daily as prescribed and achieve and maintain an undetectable viral load have no risk of sexually transmitting the virus to an HIV negative partner. We also discussed the benefits of U and U equals to U. And some of the benefits were it removes stigma and discrimination. It also creates demand for routine viral load monitoring. It was also emphasized that U equals to U does not apply to blood transfusion. U equals to U does not apply to exposure to contaminated needles. U equals to U does not protect from other sexually transmitted infections. Therefore, we should incorporate condom messaging for prevention of other STIs. We also talked about MTCT. Undetectable viral load is associated with very low but not zero risk of mother-to-child transmission. Thank you.
Thank you so much, Priscilla. Also, there will be two Priscillas here, so I hope to qualify each time I mention the name. So today, we'll have our National Coordinator for PMTCT, Dr. Priscilla Mulenga, who's going to take us through the didactic. And then afterwards, we're going to have a case presentation coming in from Dr. Kanda Mukuna, and this is from Lundazi District Hospital. And so we hope to have lots of interactions and learning points coming out of this discussion. It's quite an interesting discussion, and it brings out a number of things that are affecting us as we attend to pregnant women and breastfeeding women in our facilities. So without further ado, I would like to just hear Dr. Priscilla Mulenga. Are you ready?
Hello, good afternoon.
Good afternoon. How are you?
I'm fine, thank you. I can hear you loud and clear.
Thank you so much.
Okay.
So I think at this stage, I think you might want to proceed with the presentation, and then we'll get to the polling questions, and then I'll pick it up when it comes time for the polling questions. So please go ahead.
Hello and good afternoon to everyone. Okay, are you sharing from that side?
So our IT will share from here, so it's fine. Okay. Are you able to read from the screen?
Yes, I'm able to read. As has been introduced, my name is Priscilla Lumano-Mulenga. I'm currently the National PMTCT Coordinator. I'm going to take you through viral load monitoring in pregnant and also in breastfeeding women. What you are seeing on the slide now is the learning objectives for this session. We'll outline the schedule for viral load monitoring in pregnant and breastfeeding women according to our guidelines, the 2018 guidelines. And also we are going to share what we think we should be doing for these pregnant women in terms of viral load monitoring, the proposal that we have as a team. Then we are going to discuss the relationship of viral loads to mother to child transmission of HIV. Basically, is there an association between viral load, the levels of viral load in the blood, and also the risk of mother to child transmission? Then we will discuss guidelines for management. I think you are changing too fast for me. Yes, guidelines for management of unsuppressed viral load in pregnant and also in breastfeeding women. I guess we can pause here for the polling, not polling stations, but polling questions.
No, we'll be going into an election fever very soon. So, but what we want us to do is to discuss is actually the questions regarding viral load monitoring in the pregnant and breastfeeding women. So the first polling question is, and I will read, and I hope in this box you should be able to respond and you'll be prompted to answer. So a non-positive pregnant woman on ART for 3 years presents at with a 7-month-old viral load on the file. Which of the following statement is true? A non-positive pregnant woman on ART for 3 years presents at ANC with a 7-month-old viral load on file. Which of the following statement is true? She is not eligible for a baseline viral load because she has a valid viral load on the file less than 12 months. B, she is due for viral load at ANC because the viral load on file is more than 6 months old. So we can now pick the correct answer.
You have not posted the...
It's coming, it's coming.
It's coming, okay. All right, we've seen it now.
Oh, fantastic. I like the way the answers are coming very fast. So we've got 23 so far who have picked an answer. We're just remaining with a few seconds, then we move on to the next question. So I think we'll end the poll here. It's been 45 seconds, so we can end here and we can move on to the next question. So question 2, what is the purpose of viral load testing 1 to 4 weeks before delivery? What is the purpose of viral load testing 1 to 4 weeks before delivery? A, to determine whether viral load is suppressed or not, so that midwives can take extra care during delivery to protect themselves. B, to determine whether the pregnancy is high risk or not for the purpose of deciding duration of enhanced postnatal prophylaxis. C, to decide whether she should be switched to more potent drugs. D, all the above. Sorry. So you have the options A, B, C, and D. So we have about another 30 seconds in which to respond to this question. Okay. So we have increased the time to about 1 minute and 15 seconds. So we've got more time to think through which could be the correct answer. So 40 have participated so far. What is the purpose of viral load testing 1 to 4 weeks before delivery? So we'll close the polling for this particular question and move on to the next one. Question 3. Which of the following is true about management of viral load for pregnant breastfeeding women? A woman on first-line ART who has an unsuppressed repeat viral load after ESC and good adherence should be switched to second-line ART. To improve facility monitoring of viral load coverage among pregnant and breastfeeding women, it is necessary to have a separate viral load register in MCH. Booking women for viral load collection date at ANC is a good practice that can improve viral load coverage in MCH. D, all of the above. Okay. So we've got 7 people and increasing. You have another minute. Decide which one is the best here. Which of the following is true about management of viral load for pregnant and breastfeeding women? Okay, we'll be ending the polling very soon. So I'm going to share some results for this polling so that we see how we have done so far. So this is the first one. Sorry, the third one. And we can look at how our responses was on the first question. So most picked B. And then the second question. Some thought it was all of the above. Others thought it was B. Okay, so at this particular time, I'm going to hand over to Dr. Priscilla to pick it up and do the afternoon session. Pick it up, Dr. Mulenga.
Thank you very much, Dr. Kozia. I'm now picking it up from here. I should mention that viral load testing and monitoring, it's an important component of HIV management for all different populations. When we look at our UNAIDS 90 targets, or is it 95 targets, we all know that the third 90 actually applies to viral load testing and monitoring, and whether it is suppressed or unsuppressed. So this is something that is key, and much more for our pregnant and breastfeeding women, because we are not only looking at the patient or the recipient of care, but you're also looking at the risk of mother-to-child transmission. So you have more patients when it comes to a pregnant woman, because you're also considering the infant. Okay. So when we revise our HIV management, we emphasize on the goals to therapy, and one of the goal is to reduce transmission. And how are you going to know if the transmission is going to be reduced? Is by knowing the viral load. Okay, it's by knowing the viral load. So we are emphasizing that viral load, especially in a pregnant and breastfeeding woman, is very, very important. Okay. Next slide, please. Yeah, so how do we define viral load? Okay, viral load, just as a reminder, it's we are looking at amount of the virus, the HIV in the blood, or you can say the presence of detectable HIV virus in the in the blood. Yeah. So for someone who is on treatment, we do not expect, and they are doing well, they are responding well, we do not expect virus to be multiplying in the system. Okay, they should be undetectable, they should be unsuppressed, they should be undetectable and suppressed. Sorry for that, for the mix. Okay, so we do not expect active multiplication of the virus for someone who is doing well on the ART medication. And what do we mean by suppressed viral load? Okay, we attach a figure there, and a suppressed viral load should be less than 1,000 copies per mil, at least according to our guidelines. We expect someone who is doing well, okay, on treatment, to have a suppressed viral load of less than 1,000 copies per mil. Anything above that, we regard it as unsuppressed, and it shows that there's a problem and we need to intervene. Okay, so in our guidelines, plasma viral load above 1,000 copies per mil, based on 2 consecutive viral load measurements after 3 months, and with good adherence, is considered as virologic failure. Okay, so virologic failure is the first step. I'm seeing something like there's no volume. Are people able to get me?
We can get you very loud and clear.
Yeah, but in the chat, it's like there are some people who are struggling with volume.
I think it's
so don't worry about that.
Okay, all right. We can proceed. We can proceed. Okay. I was explaining virologic failure. Okay. It's where you have unsuppressed viral load more than 1,000 copies, and you do a repeat within 3 months. The viral load is still unsuppressed, despite improvement in adherence support, that is defined as virologic failure. Okay. So virologic failure means there's active multiplication of the virus in the blood, and sooner or later it will lead to immunologic failure, meaning the CD4 count will start going down, and then clinically the patient will start manifesting with different types of HIV-related illness, and eventually manifesting with opportunistic infections. So when someone has virologic failure, we need to intervene, okay? Then what is a blip? In short, a blip is a low viremia that occur from time to time in someone who initially had undetectable viral load, okay? So a blip may not necessarily mean that someone is failing. So there's need to closely monitor that patient and make sure that you repeat. If it's a blip, the repeat viral load is expected to be suppressed. Next slide, please. So on this slide, we have put out 3 studies that have been done within our region. Okay, one was done in South Africa, the other one in Kigali. Yes, Kigali is in East Africa, but it's within the sub-Saharan Africa, and the last one here in Malawi. Okay, so basically the message is the message from this slide is that there's a relationship between maternal viral load and the risk of mother-to-child transmission of HIV. Okay, so for the first one, what was found is that the maternal viral load was the single most important factor associated with HIV transmission or infant death, with that hazard ratio of more than 1.54. Okay. The second one, it showed that half of the MTCT was amongst pregnant and breastfeeding women who had been on ART for 2 to 7 years. This may be a bit surprising because by assumption, 2 to 7 years of treatment, you expect these women to have had a suppressed viral load. So most likely it could be, okay, these women were not suppressed. Okay, despite being on treatment for this long, the viral load suppression may not have occurred. So it's important to ensure that we are able to monitor our women with a viral load and to, with confidence, state that they are suppressed. When they are suppressed, then we are assured of a reduced mother-to-child transmission rate. Okay. The third one from Malawi, again, it showed that where you have active viruses in the blood, or where you have detectable viral load, okay, there will be a 17-fold increase in the risk of mother-to-child transmission. Next slide, please. So for more information, you can actually get back to these studies so that you understand that it's important to have these women, especially as they go into delivery, to have their viral loads suppressed. This slide is highlighting the clinical tasks and the laboratory tests that should be done to a pregnant woman and also a breastfeeding woman. Okay, I will focus on the viral load. Okay. So for this one, it's new on ART. Okay, for this slide, it's new on ART. So if this woman goes for the first antenatal booking, what we call ANC1. These are the tests that need to be done and the clinical tasks that have to be done on this woman. So if this woman has never tested, they need to be tested and prepared for test and start. They need to be initiated on treatment. So for a new pregnant woman reporting for the first time and testing for the first time and being initiated on treatment for the first time at the ANC1, just like any other adult, you do not need to do a viral load. You're going to do a viral load just like any other adult at 6 months, okay? In the general population, adult and adolescents, we know that our first viral load test is done at 6 months. So this also applies to a pregnant woman. 6 months on ART, the pregnant woman is eligible for the first viral load. So I'm emphasizing, I'm looking on a new patient, okay? The patient who has just been tested and just been initiated on treatment. So on the booking, you do not need to do a viral load, okay? But you are going to have a woman who's been on treatment and they are referred, let's say, from the ART clinic, okay? The scenario is different, okay? The scenario is different, and I think we are going to discuss as we progress. Next slide. Okay. So let's now discuss the non-positives. Okay, these are women who have been on treatment. When they become pregnant, how do we handle them? Okay, like I have said, we do all the tests, all the tasks that have been highlighted on this slide. Okay, if pregnant, of course, the focused antenatal care, you review adherence since this woman is on treatment, reinforce adherence counseling, emphasize on the pH positive health, dignity, and whatever messages, review the lab tests she's coming with from the ART clinic, and of course you need to refill the combination ART with enough supply to the next ANC visit, okay? So concerning the viral load, okay, in pregnancy, we need to be doing viral loads every 6 months during pregnancy, and also you continue during breastfeeding period, okay? Maybe just to mention that data as of now, it's showing that we are having a lot of new infections in our exposed infants, mostly during the postnatal period. So we have quite a number of women who may be on treatment, but their viral loads are not suppressed. So as they continue breastfeeding, they are continuing to transmit the infections to our infants, the HIV exposed infants, okay? Likewise, even those who are negative, okay, when they seroconvert during breastfeeding, they are also adding a significant number of transmissions to the HIV exposed infants. So we need to make sure that these women, they have their viral loads done at recommended times and ensure that the viral loads are suppressed, okay? So every 6 months, and then we are emphasizing on viral load 1 to 4 weeks, okay, before delivery. So if you get back to mother-to-child transmission, you're going to see that much of the transmission, they occur around the time of delivery, 10 to 20% or so of HIV infections to infants. They occur during pregnancy. Of course, we know that 5 to 10 it's during pregnancy, and also 10 to 20 during postnatal. And during postnatal, it depends also on the length, the duration of breastfeeding. We know this is a breastfeeding country, so most of our children breastfeed, and it has been estimated that the mean duration for breastfeeding in our country is about 20 months. We do encourage our women, regardless of the status, to actually breastfeed. Okay. So this slide is showing the SOP for viral load testing for pregnant and breastfeeding women. Okay. The first bar there indicating non-positive, and in brackets KP. I think we are trying to avoid the use of KP referring to non-positives, because for obvious reasons it will confuse people. Okay, but basically for the sake of this presentation, we have used it. Non-positive here, we have put in brackets KP on ART for more than 6 months. Okay, you need to make sure that you check the viral load on file. Okay, and then establish whether this viral load is within 6 months or after 6 months. Okay, if it's within 6 months, you collect the baseline viral load at ANC1. Again, there's confusion in terminology. When we say baseline, okay, it may mean differently to different people. So what we are trying to use, the term that we are trying to use, instead of saying baseline viral load at ANC, I think we want to propose entry viral load at ANC entry viral load, just to avoid this confusion. Okay, so when we say baseline viral load, you know, some people would think it's the baseline when they were first initiated at on treatment. Okay, so you collect the baseline viral load at ANC if the viral load on file is more than 6 months, because we are saying in pregnancy we need to do it every 6 months. So if it's more than 6 months, the viral load that she comes with from the ART clinic, then it means that she's due, as she's being booked for antenatal, she's due for the next viral load. Okay, then book for the next viral load in 6 months. Okay, and also a viral load 1 to 4 weeks before the expected date of delivery, so that she's aware that at 6 months I need to do another viral load, and also before I deliver I need to do another viral load. Okay, so the viral load 1 to 4 weeks before delivery, it will show us whether the child, okay, if it's suppressed, then it means that child, the risk of seroconverting, or the risk of acquiring the HIV is low, and we term those children as low risk infants. But if the viral load is more than 1,000, meaning it's not suppressed, then we know that we should expect that that child is high risk and we need interventions. Okay, when looking at the same chart, if the viral load is within 6 months, okay, it means as you are booking this mother, for ANC, this mother may not need the viral load, okay, at booking, but you book for the 6 months viral load and also for the 1 to 4 weeks viral load before delivery. Okay, I hope I have not confused anyone. Let's now look for the non-positives, most likely coming from the ART clinic. Okay, these are women who have been on treatment. If they've been on treatment for more than 6 months, you book them for 6 months viral load and also for the 1 to 4 weeks viral load. So in summary, concerning this SOP, a pregnant woman needs at least 3 viral loads if they've already been on treatment during the time of their pregnancy. But if they are just getting initiated, they need at booking. If they are coming from ART already on treatment, they need at booking if the viral load on file is more than 6 months, and also a viral load 1 to 4 weeks before EDD. So for both the viral load 1 to 4 weeks before delivery, it should happen. Okay. Next slide. Okay. So this is the algorithm that we have in our guidelines, and it's not just specific for the pregnant woman, but for all patients in general. Okay. So patient on treatment for more than 6 months, they are eligible for the first viral load should be done at 6 months. It's routine. Okay. They need to be tested at 6 months. They repeat at 12 months. Thereafter, it should be every year on an annual basis. So it's at 6 months, 12 months, and on an annual basis. Okay. Then for a pregnant woman, we are emphasizing it's the more frequent viral load, okay, every 6 months, because we want this mother to be suppressed by the time they go into delivery. Okay. And with that, we are going to reduce the mother-to-child transmission. Okay. Then within 4 weeks before labor and delivery is just to inform us whether there's still high risk of transmission to the baby or the risk has reduced, okay, depending on the suppression levels. Okay. Then any patient with suspected clinical or immunological failure definitely will need a viral load. Okay. So if a viral load comes out less than 1,000, okay, it means this patient, this client or the recipient of care is doing fine on treatment. The virus is not actively replicating. So you enforce the adherence support and you continue the medication, the HIV medication. Repeat viral load at 12 months post-initiation, then routine annual viral load. Okay. On my right, if the viral load is more than 1,000 copies per mil, it means we need to monitor this patient closely. Okay, this is not what we expect. It means the virus is multiplying. And when the virus is multiplying actively in the presence of a drug, that is not a good thing. Okay. So you do enhanced adherence. The first thing is to find out why is the virus still multiplying despite the patient taking medication. Okay, it may mean that the patient is not even taking medication. So you need to enhance the adherence, and within 3 months you repeat the testing. Okay, if it continues being high, more than 1,000 copies per mil, it may show this is virologic failure. Okay, it actually implies virologic failure is occurring. Okay, if on first line, it means this patient needs to be switched to second line. If on second line or infants or children on PI based line, on PI based first line, you need to consult. You need to consult because this may need more expertise to manage. Okay. If less than, if the initial was more than 1,000, but after enhanced adherence counseling, they repeat within 3 months, it's less than 1,000 copies, then you can confidently say there's no virologic failure. Okay, next slide.
Dr. Mulenga, thank you so much. I know you have a passion for this when it comes to this, but we would like you to do it a bit more faster because we'll run out of time. Thank you.
Okay, how much
Is that
time
okay?
are you giving me? How much time are you giving me?
Are you able to do the remaining slides in 15 minutes?
Yes, it's 15 minutes. It's more than enough. So this slide, before you waste much of my time also, this slide basically it's showing you that for pregnant and breastfeeding women, we have 3 categories. Okay, so you have the non-positive, okay, and then the non-positive with viral load more than 6 months, and the non-positive with a viral load less than 6 months, and those who will be new on ART. Okay. So when you look at the slide, okay, these numbers are arbitrary. Let's say you have non-positive women with a viral load more than 6 months. By 6 months, everyone, 20, okay, they should have had their first viral load at 6 months, okay? Then those with non-positive viral load less than 6 months, again, you have 30, by 6 months, all the 30 women should have had the viral load at 6 months. The new on ART, the 50, their first viral load will be at 6 months, and all the 50, by this time, they should have had a viral load. Okay. Again, for 1 to 4 weeks before EDD, of course, all the numbers that you had on the different options, they should have that viral load 1 to 4 weeks. Okay. Again, after delivery, during postnatal, it should continue every 6 months. Okay, the viral load monitoring should continue. Okay, next slide. So this is just a template for viral load collection in MCH. Since we are running out of time, I will not emphasize on the different components, but just to say that the name, NC, EDD, booking. So just to show the template that we need to use for collection of viral load in MCH. Okay. And these are just the sample guideline in viral load collection. Okay, it's highlighting the key elements that you need to put on the form. Okay, the facility name, the ART number, and for blood and plasma, let me not read for people. Okay, at least we can read for ourselves. Okay, a minimum of two EDTA vacutainer tubes should be used with 4 ml of blood to be collected. Then the other one, box 3, is just showing the rejection criteria of viral, the common causes of sample rejection: insufficient volume, wrong sample container, incorrectly labeled samples. Okay, I can proceed to the next slide. Okay, and then this is just the requisition form for viral load. So we need to make sure that we enter it well so that this sample, if it's for a pregnant woman, for a breastfeeding woman, and also for a child, it needs to be expedited. I think that's what we state in our guidelines. So we need to make sure that we indicate that this sample is for pregnant woman, and the lab should be able to expedite this. Okay. And the next slide. Okay. So management of high viral load in PMTCT. It's important that we keep an accurate record of the current cohorts of HIV infected women being cared for in the in the MCH department. We need to keep these women in MCH. They are pregnant. Even when they deliver, we need to follow them up in MCH department. Sorry for that. We need to enter all the viral load results in the viral load register once received from the lab. We need to keep a record of viral load samples. We need to keep a record of viral load samples drawn for these women at the facility and track results, return of these samples, and ensure results are retained to clients and appropriate actions are taken for those with high viral load. It's not uncommon to go into a facility and find, okay, these results are back in the facility and they are just heaped somewhere. They've not been taken to the clinician to make a decision. We just find a heap of the viral load results. So when results come to the facility, we need to take appropriate actions. Okay, we should not just heap the results. Okay? We do not expect to find a pile of viral load results or any other results for that matter. Okay, we need to take actions. Okay? Then we need to enter all the viral load results, the unsuppressed viral load results in the unsuppressed viral load register, and we need to fast track these to the clinicians, okay, for action. The results have to be worked on, okay? They are not for piling in the facilities. And we also need to ensure all unsuppressed women complete the enhanced adherence counseling and have repeat viral load, and we refer these to the clinicians for action. Okay. Next slide. I've already mentioned the expedited DBS, and for our infants, of course, we need to put them on prophylaxis, depending on whether we've classified them as high risk or low risk, okay? The medication is still the same, AZT, 3TC, and NVP, but what is different is the duration. 6 weeks for the low risk, 12 weeks for the high risk. We need to record full maternal ARV drug history and factors affecting adherence. If DBS negative, continue the prophylaxis until mother is virally suppressed. Okay. If DBS positive, you start the regimen in the child, you immediately start and send another sample to confirm the test. Of course, let's try as much as possible to consult with the experts. Yes, next slide. Okay, this is the nucleic acid test, the NAT laboratory requisition form. Of course, one of the challenges that we have is that this form is not filled out well. Let's try to complete this form so that we reduce the rejection rates for the samples that we take to the lab. Okay. Next slide. Yeah, this is my last slide. Yeah, you know, I have a passion for PMTCT. I have passion for what I do. I'm emphasizing that let's do what has been provided for us in the guidelines. Okay, the policy is clear, the guidelines are clear. If we implement according to what is in the guidelines, I can assure you that we are going to win this battle. We are going to reach the elimination that we are desiring, okay? So coverage for viral load testing as at now in our population is quite low. It's still below 50%. So let's put our hands together to make sure that we are doing what is expected of us in the facilities to make sure that our women have access to viral load at the recommended times, okay? All breastfeeding and pregnant women should have a viral load done every 6 months. Okay, it slightly differs with the general population, because we want to make sure that these women are suppressed by the time they are delivering, and also during breastfeeding to reduce on transmission. Okay. Then all positive women on ART should have a viral load a month before delivery to help categorize the risk status of the child. Okay, so if this viral load is high, then you know that the risk is high. If it's low, if the viral load is suppressed, then the risk is low. Okay, the final slide, I guess. Can I have the final slide? Yes. So like I said, we will try to avoid using the term KP because the meaning is different. In this case, it means the non-positives, okay? Not the key population we are used to, okay? So just to make sure that we do not confuse anyone out there, KP on this slide stands for non-positive. We need to review file to determine eligibility for what I'm saying. We'll be calling it as the ANC entry viral load and not baseline. Okay. Then we need to book for the next viral load, including the 1 month before delivery. For newly initiated at ANC1, we book them for the 6 months viral load and also for a month before delivery. Okay. For those with unsuppressed viral loads, we should enter them in a high viral load register so that we can intervene, okay? Then undergo enhanced adherence counseling according to our guidelines. We repeat viral load after 3 months of enhanced adherence counseling and act depending on the viral load, the second viral load result. Okay, those with unsuppressed, of course, this is what I've just said. The second viral load within 3 months done, then it means they are failing and we may need to switch them to second line. Okay. Final slide.
So thank you so much, Dr. Mulenga.
I know you really want to shut me.
No, not at all. We want also to be infected with your passion. So you can go ahead.
Okay. So let me just acknowledge, okay, I do not work alone, so I need to acknowledge the people who contributed to this presentation, okay, before you go into your polling question. Okay,
please go ahead.
Let me just acknowledge my team, okay? I won't mention name, I'll just say my team in PMTCT. Let's continue doing what we are good at, okay? I recognize Dr. Mwangelwa Muviana, Dr. Msangwa, and also from UNICEF, from WHO, Dr. Chitembo, Dr. Malumo. I think we've been a good team. Thank you very much.
Dr. Mulenga, we applaud you for such a great presentation. I know you picked this up, and yesterday you were coming from very far away with a very perilous journey, but you still managed to be with us this afternoon. Thank you so much.
Yes, this is my passion. I do not want to see any child being infected with HIV.
No. We are already contaminated by the passion as well. Sorry, infected by the compassion as well, the passion. So we'll go back to our polling questions so that we may just revisit the questions that we had. And then the first question is, a non-positive pregnant woman on ART for 3 years presents at UNC with a 7-month-old viral load on the file. Which of the following statements is true? We're relaunching, eh? Mm-hmm.
Yeah. Okay, come on.
After the learning process, how are we doing?
Has learning taken place?
Okay, so we'll end the poll right here 45. At 45, and then we'll share the results. So, Dr. Mulenga, please run us through this one.
A non-positive pregnant woman on ART for 3 years. Okay, so this is a KP. This is a non-positive, a KP already on treatment, and presents to ANC1 with a 7 months old fowl on 7 months old viral load on fowl. Which of the following statements is true? She is not eligible for a baseline viral load because she has a valid viral load on fowl less than 12 months. Okay. Then the other one, she is due for a viral load at ANC1 because the viral load on the fowl is more than 6 months old. Okay. So I should provide the explanation here.
Yes.
Oh yeah. Yes, I think what we are using now, according to our guidelines, it should be 6 months. And like I've been emphasizing, anything within 6 months, it's acceptable as valid. We may not need to do one at viral load, at ANC1 booking. But when it's more than 6 months, as in this case, she's due for the next. And let me emphasize that viral load in pregnant women and breastfeeding women, okay, it's every 6 months. Okay, so the majority have got it right.
Sorry, question 2. So what is the purpose of viral load testing 1 to 4 weeks before delivery? A, to determine whether the viral load is suppressed or not, so that the midwives can take extra care during delivery to protect themselves, to determine whether the pregnancy is high risk or not, for the purpose of deciding duration of enhanced postnatal prophylaxis, to decide whether she should be switched to more potent drugs, all of the above. Dr. Mulenga.
Yes.
Could you kindly explain the answers, the correct answers for us?
They are still...
They're still polling?
They're still polling.
Okay, I'll end it now after 5 minutes. So those are the results. So you can just explain to us the answers?
Okay.
So why is it?
Yes. For that viral load a month before delivery, we would want to assess the risk of transmission of the virus to the infant. Okay? If at the time of delivery the viral load is high, meaning it's not suppressed, it means that there is that high risk that this child may acquire the infection. Okay? If it's low, it's the risk is low. Okay. So what does that mean? It means a high-risk child should be managed differently in terms of prophylaxis, and also a low-risk child is also managed differently. Yeah. So looking at these options, let me just go through them. Just a minute. Take me back to the second one. To determine whether the viral load is suppressed or not, so that midwives can take extra care during delivery to protect themselves. Okay. In as much as it is important to take extra care during, we need to practice the infection prevention procedures to protect ourselves, but it does not explain, okay, why we should do the 1 to 4 weeks viral load, okay? Then to determine whether the pregnancy is high risk or not for the purpose of deciding duration of enhanced postnatal prophylaxis, then to determine whether she should be switched to more potent drugs, then all the above, okay? Of course, B, it's explaining why we do it, and yeah, that's the main reason we do this 1 to 4 weeks viral load before delivery.
Thank you so much. So we'll move on to the next question. So the next question, which of the following is true about management of viral load for pregnant breastfeeding women? A woman, okay, so we can read and we can pick the best answer from this one. I'm not seeing so many people participating in this question. It's not clear? Only a few. Okay, so end the poll here. Only 27 have voted. Oh, 29 now, 30. Okay, it's been over a minute, so we'll just end the polling. So the correct answer for this particular question is D, all of the above. Dr. Mulenga, would you want to explain why D is the correct answer?
A woman on first line, yes. A woman on first line. Yeah, so for the first option A, a woman, not a woman, a woman on first line ART was an unsuppressed repeat viral load after enhanced adherence counseling and good adherence should be switched to second line ART. I think this is what needs to be happening. Okay, so this on its own, it's correct. But let's see what others also, what we can get from others. And the option A, we should be doing it as quickly as we can in the facilities. Okay, that's why I emphasized we do not want to find heaps and heaps of viral load results. Okay, high viral load results. Then to improve facility monitoring of viral load coverage among women, it is necessary to have a separate viral load register in MCH. I think this is what we are recommending. Okay.
This sounds like a very good practice, not so?
Yes, it is a very good practice. Okay. Then booking women on viral load collection date at ANC is a good practice that can improve viral load coverage. Remember, we have said that our coverage is quite low. We need to improve
Yeah.
this. So doing booking at ANC1, we are also like empowering our women. They should know that at this visit, okay, they should expect a viral load to be done. If it's not done, they should also actually demand. Okay, last time I was informed that I need a viral load at this visit. Okay, so with that, we can actually improve the coverage of viral load. Yeah.
So this actually, the best answer is D. It actually, for all these are the best answers. So thank you so much, Dr. Mulenga. We appreciate. At this particular time, we would like to ask Dr. Kanda and Tim Lundazi to begin preparing their slides and to share. But in the meantime, we've got two experts here on the subject who have come to join us. There's Panji and Sister Febi. I don't know if they've got any comments they would like to make before we move to the spokes.
Thank you very much, Doctor. That was a very good presentation for us midwives. I'd just like to echo the midwives in the MCH that testing the mothers in the in the last month of pregnancy, the first for the first to 4 weeks before delivery is a good practice because it will help us to pair the mother and the woman in the breastfeeding period. What does this mean? It means that when the mother will be due for viral load 6 months after delivery, this is the time that we'll be also collecting the DBS for the baby. So they'll be moving in pairs for all the activities. So I thought we need to bear this in mind, that it will be good practice to do that so that we make it like a mark for the breastfeeding period. And also in Chingilanga district, I think this has been very good and clearly defined or clarified, because there were a mix-up of baseline viral load, because they thought that all mothers that come to antenatal booking, we need to do the first line baseline. But then here, I think it has been clarified, and with the use of the SOPs, I hope the midwives should be able to use this to guide us so that we are able to protect the baby from being infected. Thank you.
Thank you so much. Panji, would you like to say something?
Yes, thank you very much for that wonderful presentation. I think from the lab's point of view, I just want to emphasize on the acceptability criteria for the specimens that are coming into the lab. I think that we have to pay specifically more attention to how we collect specimens. I know that different facilities have got challenges, especially when it comes to the collection bottles that is recommended for viral load. So we actually recommend that we use the purple bottle for HIV viral load. And then the other thing I wanted also to make mention is the of ensuring that the forms are also complete, because sometimes the patient's requisition forms are sent to the lab and then the forms are not complete. And then that creates a problem, especially for the patient, especially that they were mentioning that these tests should be done maybe a month, 1 to 4 months before delivery. So we want to have a situation whereby when the specimens are being sent to the lab, the acceptability criteria for viral testing actually have been adhered to. So I would encourage that if you are not clear on how the specimens are supposed to be collected, the volumes and whatnot, please just make sure that we are in consultation with the lab so that those issues are actually sorted out. I think the other last thing I wanted to make mention also is the issue of results. I know that the results, there's a lag between the results. When the results are ready from the lab, and when the results are being sent to the facility. So I would also encourage that there should be that rapport or communication between the lab and the clinician, because if you are not communicating, most of the time the results for the lab are ready, but then there's that lack of communication which is there between the lab and the clinician. So I would encourage that let's communicate and ensure that these results are sent to the clinic or facilities on time. Thank you very much.
So thank you so much. We've really run out of time, but I think I would like to allow Mongu. They've raised their hand. If you could just unmute yourself and then just make your comments, and then we'll respond to the questions that have been raised in the chat. Urban.
Okay, thank you. Sorry, our camera is down, but you can hear us. Can you hear us?
Yes, we can hear you. Just make it very quick.
Okay.
The question is, first of all, thank you very much for the clarification, but let's just make sure that we've gotten it right. I don't know if you, Dr. Mulenga, you're saying when the mother has a high viral load, a breastfeeding mother, we should not stop prophylaxis to the child until the mother is virally suppressed. I want to get that very correct. And then the other question is, if the infant had stopped prophylaxis, then in the course of every 6 months viral load testing, then you find this mother who is still breastfeeding has now a high viral load. What do we do for the infant? Then the third one, on the timing for viral load, maybe for us to make it easier, because we are using the cohorts after breastfeeding, after birth in the 0 to 3 months. Why don't we make the viral load monitoring for the pregnant women also to follow the timing so that we take them as a cohort? That on a page, like for August cohort, you know that all these women will be testing them at specific times following the register, so that we don't leave room for so many appointment dates for the viral load, since we are looking at them as a cohort. Thank you.
So, Dr. Mulenga, have you heard the questions?
I think I have. If it's not clear, I will seek clarification.
So the first question, I think the first question is about the viral load being high in the mother, and then the infant is breastfeeding. I don't know. You can attempt to answer those questions.
It's not just attempting. I will answer them.
Okay.
Yes, when the viral load is high in the mother, of course we know that the risk of transmission. This is a breastfeeding woman, right? Yeah. So if the viral load is high in the mother, definitely the risk of transmission is high. Okay. So as at now, I would advise that we follow what is in the guidelines, but I should also make mention that there are some scenarios that we have realized that we have not explained well. Okay, ideally you would want to stop the prophylaxis when the mother's viral load is suppressed. Okay. But there are situations where the mother's viral load is not suppressed, and we have not clearly defined, okay, in the guidelines. So we are actually working as a team to make sure that certain scenarios that are being experienced in the facilities are also like addressed. We provide that guidance, okay. But for now, let's go for the 12 weeks high risk and the 6 weeks low risk. Okay. Of course, for the unsuppressed, we know that when we stop, the risk is there, but we are trying to address it. Okay. We do not want to say it now that continue after 12 weeks, because if this woman was initiated at delivery, we expect by 12 weeks, okay, suppression should have set in. Okay. Yeah, but we are still considering, of course, okay, looking at a scenario where the woman refuses, okay, to take the ART. So then that is a challenge. How do we address that? For how long do we give the prophylaxis? Okay, so it's the prophylaxis after 12 weeks if the woman is not on treatment and she continues to breastfeed. So that's where we need to provide some guidance. Okay. Otherwise, if this woman is on treatment starting from delivery, by 12 weeks, we should expect that the viral load should be suppressed. Okay. That's for the second question. I don't know whether it's clear. If the one who asked is satisfied, okay. Then the second one was on what?
So I think you've partly answered even the second question from your explanation.
It was.
Yeah, I think you've partly answered it. So I think for, maybe we could, because we've really run out of time, and I'm hoping we could have a feel of what a case we had, a case scenario that we had. We might learn one or two things from it as well, because it raises similar concerns as well. And I think
maybe just to say that cohort monitoring is one of the interventions that we are advocating. So this proposal on cohort monitoring, okay, it's something that we are actually working on. Okay.
Oh, okay, thank you so much. And then the comments on the chat group, there was just, Dr. Jinwala, there was just an error on one of the questions. Instead of pregnancy, should have been an infant. That's why that one is correct. And then the other questions, let's refer to the slides. They have actually all the answers for the other questions. So this time, I'll just invite Dr. Kanda Mukuna to actually share their slides. Lundazi, are we there?
So as we are waiting for Lundazi to share their slides, this topic was really motivated by what we found in facilities. We're finding that actually the breastfeeding women are not getting frequent viral loads, neither are the pregnant women, and that's why we requested to do this topic. I don't know if Leonard, you're able to unmute yourself and tell us the Namibia experience with seroconversion in women who are pregnant and breastfeeding, what are your rates, and how it relates to elimination of mother-to-child transmission. But Lundazi, please go ahead and share.
Yes, Sompo, thank you very much, and this is quite an interesting discussion. So our PMTCT rates currently in Namibia, they're just less than 4%, and what we are seeing now is more for transmission happening during the breastfeeding period, and that's our major concern now. Mostly, some of the reasons, maybe if I can quickly share, is women were defaulting treatment after delivery. We are also seeing a number of women who are testing positive for the first time during the breastfeeding period, and those babies are getting to seroconvert. So we've put in place PrEP for postpartum. So anyone who is HIV negative, we are putting them on PrEP if they are at risk, just to cover that part. We have reduced the viral load monitoring of pregnant women to 3 months, every 3 months, even during breastfeeding, so that we are able to continue to cap that transmission during that part. So it's a difficult topic, especially implementation wise, because of the vastness of the geographical area in Namibia, and also the distances where women travel. In some parts, especially remote areas, not all women are delivering in health facilities, and this becomes a lot of gaps that are sort of contributing to that. Thank you.
Thank you so much, Leonard. That's very useful, in particular where you are saying you are seeing a lot of children getting HIV because women are seroconverting during the breastfeeding period, and Namibia is doing it more frequently. I think that's useful. Dr. Kanda, are you able to read your slide set now? Lundazi?
Lundazi, you can unmute yourself and begin to share. You only have a few minutes. Lundazi.
Dr. Kanda, we've shared the slides. Please go ahead. Davis, while they're trying, you can just go ahead and read the slides if you don't have the time.
So we will ask Davis to read for us the slides as the team in Lundazi is preparing themselves. Okay. 37 years old, tested HIV positive on 22nd of June 2016. Commenced on TLE on 23rd June 2016. Married, but had not earlier disclosed about her status to her husband. The couple has 4 biological children. The first, second, and third children, respectively, 14 years, 12 years, and 6 years old, were all tested HIV negative. The last child, who is 7 months old and still breastfeeding, had 2 DBS done at 6 weeks and at 6 months. They both did not detect any viral DNA. And the latest husband remains HIV negative in May, as of May. Lundazi, are you able to pick it up?
Are you able to unmute them?
So I'll continue reading on their behalf. So physical examination, this was just a stable and clinically stable woman. The BP was normal, the pulse was normal, the temperature was normal, height and weight slight on an overweight side, according to the BMI. Next. And the results. So in terms of ART regimen, she was started on 23rd June 2016 on TLE. And the last child, a few details on the last child. The child was born on 29 January 2019. Lundazi, you are on.
Yes. So the woman has got only one viral.
Please just start from this slide,
So,
Dr. Kanda.
Dr. Kanda, you can just speak from the clinical timeline and the lab results. You can run us through this session. Thank you.
Thanks so much for that, Dr. Kozia. The client has got only one viral not found in the farm. This one was ordered before delivery, and it came after delivery, and the result, it was not detected. She has got as well one CD4 count which has been ordered. The result was 156 cell, and the HP was 12 gram per deciliter. She was started on TLE on the 23rd June of 2016. The last child, the date of birth was 29 January 2019. Birth weight was 3.7 kg. Currently, the feeding with no other complaint. The baby was initiated on prophylaxis for 6 weeks and is currently on Septrin. DBS was and at 6 months, and the result was not detected. For the husband, he was tested HIV negative in 2019 May. Dr. Kozia, can you show us the second slide, the following slide? I will put in questions. We are asking following questions. What should be the ideal viral load, the test profile for this woman from the time of ART initiation to date? How can we proceed with the viral load monitoring in this woman since she is virally suppressed? Thank you so much.
Thank you so much. Thank you so much, Dr. Kanda. I know we've had some IT challenges from that end, but thank you for coming through. So the summary is that we've got a 37-year-old female who gave birth to a child about 7 months ago, and the child is currently undetected. The woman is, according to the last viral load, she's suppressed. And so the questions that we have right now is that we've got this suppressed woman, and we need to decide how we are going to monitor her ongoing, and what could we have done better from the time that we had an encounter with this child. So is still breastfeeding. We need to keep that in mind as well. So at this stage, would have invited for some spokes, if they've got any one or two people from the spokes who would like to say, give a response to these questions. We'll give you about 10 seconds, 15 seconds to show up before we ask our expert presence to just guide us on this one. Is everything clear about the case? If there are any questions about the case, please do ask. But if there are no questions, then you would like to offer an answer to the questions that the Lundazi team is asking, feel free to respond before we ask the experts.
We have a question here in the same case. Hello?
So, yes.
Dr.
Yes,
Bosco
Dr.
here.
Bosco.
Yes, yes, I don't get any case there because the viral load of the woman is suppressed. So what is the challenge? Because the woman, although she's breastfeeding, will still follow the normal guideline on the viral load monitoring, as it is in our Zambian guideline on page 36. So you can check that. We should do that viral load every 6 months. She's suppressed, by the way. A breastfeeding and a pregnant woman, we do that viral load every 6 months. That's my contribution. Thank you.
Thank you so much, Dr. Bosco, for that contribution. We have a hand from Mongu. Aben.
We had withdrawn our question, but regardless, we had a question to do with PrEP, to find out whether the man is on PrEP and why we missed the the birth DBS on the child.
Okay, so the man refused PrEP.
Thanks so much.
Yes, Doctor.
For the question, Precious, I just want to let you know that the day the man was tested for HIV, he was approached well. He was linked the same day to preventive measures as well, like the VMNC, PrEP. But the husband declined these measures. He found for himself it was normal to remain as he was without taking PrEP and without being linked to other measures like male circumcision. Up to now, we're still going on with the counseling. If we can link husband to these measures as PEP and PMMC.
Dr. Sombo.
Bosco, I would like to give a comeback to your response. I believe the first question is asking, is this ideal for a patient who's been on ART since 2016 to have one viral load? So the facility was asking us, is this how an ART file should look, to have one viral load done at some point when she was pregnant? And I think this is not ideal. This lady should have had a viral load somewhere in 2016 at 6 months. We should have seen something in 2017. We should have seen something in 2018. It's great that she's suppressed, but this is not the ideal profile. She has a lot of missed viral loads on her file. I'm sure you want to take the second question, Bosco.
What was the second question again, please?
Doctor.
What was the second question? I want to take it, yes.
So the second question is, how can we proceed with viral load monitoring in this woman since she is suppressed?
Yes. Hello, can you hear me there?
Very much.
Yes, since she is breastfeeding, on a breastfeeding woman and a pregnant woman, it is better to do the viral load every 6 months. That's number one. When she stopped breastfeeding and if the viral load is suppressed, she will fall in general category where we're doing the viral load once per year, once every 12 months. But for now, since she is breastfeeding, it will be prudent to have the viral load every 6 months for the breastfeeding woman.
All right, so thank you so much. We've really run out of time completely. This is 16 hours. So I'm just going to invite Dr. Priscilla Mulenga to give an answer in 3 minutes, just to let us know about what we can recommend for this Lundazi team in the way they can manage this client. Dr. Priscilla?
I was actually just preparing to my final remarks, because I've seen there are still more questions on the chat that we have not responded. I would like to say that what Namibia brought out, okay, the picture is fairly similar to our program. We are also seeing new infections during the breastfeeding, period, and most of this infection is coming from those mothers who get infected either late in pregnancy or during breastfeeding, okay? And also those who drop off, those we lose to follow up, okay? Then maybe just to comment on the 1 to 4 weeks viral load, because I'm seeing a lot of questions from the chat. Yeah, so the 1 to 4 weeks, like I said, it helps us know the low and the high risk HIV exposed infant, so that we make an appropriate decision, okay? It can be in terms of the prophylaxis, but also it can also be in terms of where it's possible to give a more potent drug. So let me be quick to mention that after the information on the shift on the new HIV infections, as a team, we're actually coming up with a prevention package so that certain things can be defined. And in that package, we expect that we'll come up with maybe guidelines for PrEP for these women. And also we'll come up with things like maybe clearly define which drugs can we move to if, okay, we find that that viral load is still not suppressed. Okay, so it's to help us determine the risk. Is it high or it's low? And making appropriate intervention. For now, we can say to do with prophylaxis, but when we are clear in our package, we can also bring in what drug can we advocate for. Okay. On the Lundazi, sorry, I missed the last question. I thought the first question someone answered it well.
So the last question is, how can we proceed with viral load monitoring in this woman since she is suppressed?
Yes, it's good that she is suppressed, but we still need to continue doing the 6 monthly viral load until she's discharged from the program at when the baby is 24 months. Okay, we need to ensure that we are hoping by 24 months this child will stop breastfeeding. Okay, but even if that child continues breastfeeding, as long as the viral load is suppressed, okay, the risk is low. So we need to continue the 6 monthly viral load monitoring in this child. Okay, we need to maintain the viral load suppressed until she's discharged or until she stops breastfeeding. Okay, in this regard, again, I'm seeing a question on the chat about a woman with persistent high viral load. They seem to be stuck. They seem to be stuck with whether to stop the prophylaxis. The child is 7 months. I think this question is coming from Mahatma Gandhi. I think they can get in touch with us, then we can discuss on how best we can manage that child.
Yeah, thank you so much. I agree with you, Dr. Mulenga. Some of these cases you might want to just ask for expert opinion so that you can, because they tend to be isolated cases. I see that this topic stirred up a lot of questions, a lot of interest, and we had little time. I'd hope maybe we could have done this in 3 hours. But anyway, we have to come to an end. So the question for Lundazi, I hope they've been answered. The first question, this is not an ideal way of managing a viral load monitoring for a pregnant woman. So there were some missed opportunities, and I hope that we can go on the ground.
Press on Zoom. I go on Zoom.
So we want to thank also the other team people that participated in developing these materials, Dr. Keith Mwewo and the others. We thank you so much, Dr. Mulenga. We appreciate you and your passion. And Dr. Mukuna from Lundazi, thank you so much for this wonderful case that you presented. And to the rest of the SPOC, thank you so much for coming through. And this is where we shall close it today.